So that was quick, but that was a wonderful presentation. We're moving now into what we are calling our Saskatchewan Snapshots. These are quick, brief presentations, and this next session will build upon Dr. Shahad's presentation, which is really looking at the latest in local COVID-19 research. And by local, I mean in the province of Saskatchewan. And as you can imagine, most of this is research in progress because we're not far enough along to really appreciate, and that's certainly what Dr. Shahab spoke to, is that we don't know enough about what we don't know yet. So this is some of the newest research ongoing. These presentations today, they'll have 10 minutes in total. Hopefully the presentation will be between 6 and 7 minutes and save just a very mere 3 minutes afterwards for some questions. Again, please use your chat room for questions. And again, when we do get questions, introduce yourself. Presenters, please, I'll try to make a tone or an unannoying beep when you're getting towards the end there. The faster we can go, the more time there is for conversation, which I think is critical as we all stare at our computer screens here. So our first presenter this morning is going to be with Dr. Milne and Dr. Reed. They're looking at translating knowledge for child welfare organizations across the prairies. And I will allow them, I'm going to stop sharing and let it switch over to them. So please welcome Drs. Milne and Reed.
Perfect. We're just going to wait for...
Yeah, good morning. Hello, good morning, everyone, and thanks so much for joining us today to hear about our project, which essentially culminated in the development of a website called the Digital Connections Hub, the goal of which is to translate, mobilize research and resources for vulnerable children and families during COVID-19 and hopefully beyond. So I'm just going to share my screen here. Great. And so again, thanks very much for joining us. We are going to talk a little bit about a project that was the result of 2 different grants that we received, generous grants that were rapid response in nature from the Saskatchewan Health Research Foundation and the Canadian Institutes of Health Research. So Natalie and I realized early on the potentially deleterious impacts of COVID-19. Even if just anecdotally, on vulnerable children and families. So some of these included increased separation, isolation, abuse and neglect, mental and physical health problems, and substance abuse. And this was alongside reduced access to all kinds of services such as health, social, and educational supports. And having worked on the front lines myself in child welfare, which is often characterized by crisis-oriented work, I am keenly aware of how challenging it can be to have the time to locate and to appraise research and resources that might improve my interventions with children and families. And this would apply for others working closely with vulnerable children and families, such as health workers, teachers, community workers, etc. All of these organizations really had to pivot very rapidly to respond to increasing demands and case complexity. And then echoing what Dr. Shahab said about the importance of real-time research and the potential for this to inform policy, as well as the importance of bridging the research to practice gap that Dr. Paluck was referring to, we really wanted to, in the end, mitigate any potential impacts of COVID-19 by providing synthesized, current, accessible information to ensure the safety and well-being of vulnerable children and families.
Perfect. So Dr. Milne and I are going to switch back and forth to speak with you today. And so in terms of how we underwent this rapid response project, we really grounded ourselves in a socio-ecological framework to consider sort of the multiple levels of the individual relationships, the community, society, that are all nested within each other, because we were trying to understand the landscape broadly. We did a significant stakeholder outreach to our stakeholders. There was 73 of them that we asked to wonder with them what were their urgent needs and how could we best respond. Simultaneously, we conducted a database and online searches. Again, to echo what Dr. Shahab said about real-time research, there wasn't a lot of peer-reviewed research coming up. There was a rapid proliferation of information and resources. And so we really looked broadly across, and it was an iterative process. So we reviewed, we found, we reviewed, we vetted, and then we moved to synthesizing. What this all led to was the creation of 2-page information briefs. And then we further distilled those briefs into 1-page posters that we then created a website to house those information briefs and posters that is hosted through the University of Regina's Child Trauma Research Center. And that's where it can, all of the materials can be found, downloaded, printed, etc., and shared.
And so in terms of our findings, through the rapid scan, we found 4 main themes, which probably wouldn't be very surprising to our audience today. So the first was the mental health of children, youth, caregivers, and service providers. So for example, increases in anxiety, depression, what we learned in terms of pandemic grief, and really an overall lack of supports and services that only exacerbated, which was already a really challenging situation. We wanted to also research corresponding strategies for all of our identified issues. So we wanted to make sure we had some suggestions for how, as practitioners, we could be responding. And so some for mental health included increased connection with families in any way possible. The recognition of the importance of continuing with or providing mental health related services, better understanding of how children and youth and us as adults, whether caregivers or service providers, can experience pandemic grief, tips on providing psychological first aid, and some anxiety reduction and self-care techniques for all ages. We have all kinds of briefs that talk about different strategies such as mindfulness, yoga, breathing, music, exercise, art, child and youth-led activities, etc. Our second main theme, which is often intricately tied to mental health, was substance use among youth and caregivers. While some maintained or even decreased use, others increased use, and this further exacerbated, again, conditions such as the opioid crisis here in the Prairies. So some of our corresponding strategies that we found included harm reduction strategies on multiple levels and increased support availability, of course, for substance use issues, closely monitoring potential youth substance overuse with tips for parents and caregivers. And then a third theme we found was around the protection of children. So this mainly related to children in out-of-home care or those involved with child welfare at home and others. And so what we realized, we needed to be aware that although there was less reporting of child abuse and neglect, we realized there was a lot less surveillance, especially with school not being in session. So we really wanted to pay attention to all of the conditions that might increase abuse or neglect during this period, such as stress, living in small quarters, isolation, increased exposure to abusive individuals, and a lack of protective factors such as school, recreational involvement, health appointments, etc. And this has been termed a shadow pandemic. And of course, we can expect that children in care would have also experienced this much more severely, lack of contact with families due to COVID restrictions, living in close quarters within group homes, financial related stress in foster homes, and then our children who are actually aging out of care. And so for these, our suggestions were to closely monitor these situations. Again, not assume because reports were down that maltreatment was actually not occurring. Using PPE whenever necessary to maintain visits, to continue with investigations, and ensuring that everybody had access to telephone and video to do check-ins and to be able to communicate with each other. For kids in care, again, checking in often, ensuring safe and sanitary conditions in homes and units, and again, keeping connected with family and friends as much as possible within guidelines. And then I just want to mention really quickly that a lot of these issues were disproportionately affecting girls, women, individuals from the LGBTQ to Spirit Plus communities, and individuals who are differently enabled. And so we did prepare briefs on that as well. Our final theme, which really encompassed everything, was communication and the importance of this during COVID-19. So what came to light is really an overall lack of ability to communicate and our difficulty for children to really understand what COVID-19 meant and how their worlds have essentially been turned upside down. And this is where we found that it was so important for us to make sure that we're not only building communication and relationships, but also facilitating communication through technology as much as possible. So this was key for all groups. And I will let Natalie show us some examples of what some of our briefs look like.
So I just saw that we have a 1 minute, probably now 45-second window. So I'm going to speak really quickly. Rather than taking you to the site for the sake of time, we thought we would show you here, but the website address is located at the bottom of the slide. And so we created these briefs and then distilled, like I said, into information posters. We wanted to shape the information in ways that was attractive and shareable and printable, but also easily consumable. People don't have time to sit and read the pages and pages of research and resources that we read. And so we worked very diligently to synthesize the information. So on the website now, there are 40 briefs with 40 matching posters, most of which are translated into French, but there are also links to other resources, other research centers, webinars, infographics, posters, articles, webinars, and podcasts that have been shaped by other organizations, because the work that has been done has been exceptional, and we wanted to become a hub, a first point of contact or a single point of contact for people to be able to quickly and easily find what they were looking for.
Thanks, Natalie. And just quickly to let you know, like with any good project, we are going to be evaluating in multiple ways.
And with any good project, it always exceeds the end of the project. And so our goal is to continue adding, growing, building, shifting, and shaping the Digital Connections Hub in ways that we can continue to support vulnerable children, youth, families, caregivers, and service providers, really anyone who cares about the well-being of children.
Quick shout out to our team. We had a wonderful, small but mighty team. Here are all our team members. So thank you, everyone. We really appreciate your attention today and invite any questions that you may have. We also have some contact information listed here for you.
That's great. I would suggest just leaving that up for a little while longer. And, you know, I'm put in the horrible position. I feel like it's Sophie's choice. As the chat room questions come in, I have to sort of decide who we're going to, which questions we can actually answer here. But very, very important research. I'm going to slip over to the chat room and see what's come in there. We have time only, unfortunately, for just one question, most likely. Okay, we're just having a little bit of IT issue here with questions coming in. So we will be recording this. For everybody that didn't know, these sessions will be recorded. And of course, your contact information is up there, Drs. Milne and Reed. So I think we can't, I'm just having a little bit of problems monitoring the chat room here, but we will invite everybody that has questions for your team to contact you directly. And on behalf of the planning committee, thank you so much for all this important work that you guys are doing. And I'm looking forward to see how it unfolds over the course of this year. So thank you again.
Thank you, everyone. Have a great day.
Oh, yeah, we're going to have to, I'm sorry, the questions now they're coming in, but I will get them to contact you directly because we're running a little bit off schedule. I'm sorry about that.
No, that's perfect. Thank you so much.
Okay.
Bye-bye.
So moving on here, we're going to move on to our second presentation, which is something that, again, we don't usually describe the pandemic as being a positive thing, but for something that we thought for so long could not be possible, providing virtual care. We see a number of projects underway in the province, and I'm really pleased to introduce our next presenter, Mars Joe. And he is going to talk about patient and provider perspectives and the satisfaction of our province for the virtual care during the pandemic. So welcome, Mars, and I'm going to stop sharing and slide it over to you, and welcome.
Thank you for the introduction. I appreciate it. And I really appreciate everyone being here and for you guys hosting me so that I can present to you guys this exciting topic here. I'll see if I can share my screen. Okay. Just double checking everyone can see this.
Yep.
Perfect.
Looks great.
So yeah, as you gave that wonderful introduction, our research is geared towards assessing virtual care throughout the COVID-19 pandemic. And as you mentioned, there are obviously a lot of cons that has come out from this pandemic. However, virtual care is an exciting area of development that perhaps could be a pro or a provid of COVID-19, if you will. So that is what our research is aiming to do. We wanted to further assess virtual care throughout the pandemic in an effort to perhaps implement it post-pandemic. And so, of course, our research is titled Patient and Provider Perspectives and Satisfaction of Virtual Care in the COVID-19 Pandemic. My name is Mars Zhao, and this research is also off the backs of Hisham El-Shoni, as well as doctors Jennifer O'Brien and Jonathan Gamble. And so we know that, as many of you guys know, virtual care has been employed as a solution for accessing healthcare during the COVID-19 pandemic while respecting social distancing. And so we define virtual care as any interaction between patients or members of their circle of care occurring remotely using any forms of communication or information technologies with the aim of facilitating or maximizing the quality and effectiveness of virtual care. And so we know that in the literature, virtual care has led to good patient outcomes, and in fact, patient outcomes that are comparable to in-person care as well. However, patient and provider satisfaction is not well detailed. And therefore, that is what this project is trying to do. We want to describe how the COVID-19 pandemic has affected patient and healthcare provider satisfaction, perceptions, and attitudes to virtual care, with the ultimate objective of identifying its advantages, barriers, and therefore potential solutions so that we can better implement it both during and post the pandemic. In order to accomplish this, we utilized a mixed methods design. And so we distributed electronically a survey towards both patients and providers that utilized virtual care during the COVID-19 pandemic. These surveys were modified from previous surveys that have tried to assess virtual care in the literature, and then they were reported using descriptive statistics. At the end of these surveys, participants were given the opportunity to further participate in a 30-minute interview, semi-structured interview, in which case these interviews were then transcribed and analyzed using thematic analysis. Most importantly, we recruited a patient partner through the SCPOR, which makes sure that our analysis, interpretation, and knowledge translation is meaningful towards patient stakeholders. And so looking at our demographics here, we know that both patients and providers within our participants are very familiar with technology. And this is an important thing to note because we know that in the literature, there's a strong correlation between technological literacy and positive attitudes towards virtual care. And of course, we see that within our results here. We want to measure satisfaction of virtual care across 5 criteria. So scheduling, technology, provider, personal, and general. And we measure satisfaction through a Likert scale. So 1 being very unsatisfied, 5 being very satisfied, and 3 being neutral. So of course, both patients and providers are above a 3 on the Likert scale, and therefore we would say that they do hold positive attitudes towards virtual care across all 5 criteria. However, it's interesting to note here that patients are much more satisfied than providers across all 5 criteria. And this trend continues into their willingness to utilize virtual care post-pandemic as well. We see that patients are much more willing to agree that virtual care is as good as in-person care, and that they would actually use virtual care in place of in-person care post-COVID-19. Whereas providers would disagree with this, and they would be much more willing to use virtual care alongside in-person care post-COVID-19. So a possible explanation for this, if I could direct your eyes to the 4th column here, is that patients find virtual care to be much shorter than in-person care compared to providers. And therefore, perhaps they're much more satisfied with virtual care as a result of this, and are more willing to use virtual care in place of in-person care post-COVID-19. However, both patients and providers would recommend virtual care towards the colleagues or other patients. And so in conclusion here, we know that the majority of our participants are very familiar with technology, and therefore this could represent a potential bias within our data, because again, we know in the literature, there's a strong correlation between technological literacy and satisfaction with virtual care, whereas the general population would maybe not have as much strong technological literacy compared to our participants. However, within our participants, both patients and providers hold positive attitudes towards virtual care across all 5 criteria, and patients in general are more satisfied than providers are. In fact, patients would think that virtual care is as good as in-person care and would want to use it in place of in-person care post-COVID-19, whereas providers disagree with these statements. And again, explanation is that patients can better appreciate the time efficiency of virtual care as they can enjoy accessing care from home, whereas providers still have to travel to their office or their clinic. And in fact, in our interviews, we know that patients find that there is less wait time in general when they use virtual care. And one of the biggest perks is they don't have to travel to a clinic. And if they are going to wait, they can wait in the comfort of their home versus waiting in a busy clinic. However, private providers strongly appreciate the improved ability to connect with patients, especially rural patients, so that rural patients don't have to travel a long way to receive their treatment, which could be done virtually. So this project is currently still ongoing. We're still recruiting patients, and we're still processing data in terms of the survey. And also we are still conducting thematic analysis of the interviews. However, ultimately, we want to elucidate the advantages as well as barriers towards virtual care so that we can identify improvements that can be implemented both during and post-pandemic. So this project was made possible due to the support of the College of Medicine, as well as the Saskatchewan Centre of Patient-Oriented Research. So thank you so much for your time. I would gladly take any questions that you guys may have.
Thank you very much, Mars. And we've got a few questions coming in on the chat room here. Mm-hmm. I'm hoping there we go. I'm trying to unmute here. I'm going to turn it over to Mamada, who has a question that I think is something that comes up fairly commonly with virtual care. So okay. Can we unmute Mamada, please?
Hello, Mars.
Hello.
Can you hear me?
Yep.
Thank you so much for this wonderful presentation and all the important data. It's really very nice to see the results of the study. So I have actually 2 questions. One is related to privacy and confidentiality when we are using the virtual care model, because as you can imagine that it might not be possible to understand who is on the other side of the line in terms of the patient. They might or might not be by themselves. The other question is related to language barrier. If a client has language barrier and needs to or wants to use a medical translator, how is that process going to work? Or have you heard anything from clients talking about those two?
Well, those are excellent questions. So thank you for asking those. So just to address the first question in regards to confidentiality and privacy, that is actually one of the concerns that has been brought up on the patient's end, and one of the more common concerns that we've heard. So, of course, I think officially, providers are supposed to be using PECSIP if they are going to do a video call. However, we know that many providers, this isn't necessarily an official platform. Many providers are using other platforms such as Zoom, as what we're using right now. And yeah, this is actually a common concern with patients because there is no standardized official healthcare platform, online platform that is to be used. So yeah, that is actually an absolute concern for patients, and that is actually one of our suggested improvements towards virtual care, is to have an official platform that is secure and perhaps more regulated in line with the SHA. So that is actually a concern for patients. And I believe, correct me if I'm wrong, your second question was. Sorry, what was your second question?
It was related to using medical translators to assist clients, whose English is not their first language. So if they need assistance there.
Of course. So we actually haven't ran into this with our patients, neither through the surveys nor the interviews. So again, perhaps that's a bias within our participant pool, where they're primarily English speaking or very comfortable with English as their primary language. So yeah, we haven't seen any data or any concerns about this from our participants so far.
So we're, thank you, Martha. We've got, I'm going to squeeze in one more question. Darn, I wish we would have left more time here because these are all just so timely. First off, I'm going to ask you before you leave, if you could put the recruitment link into the chat room. We've had a few people asking, how do we join? How do we get into this research? So I think that's the idea of connecting and celebrating. But I have one more question here from Fiona Fick. So if we can unmute her, she has a question that a few people have asked.
Absolutely.
Hi, Mars. Thank you so much for the presentation. It was really, really interesting. And it's such a good topic for us right now. But I was wondering about more nuances in the data, because I know some patients really love virtual care, but often that's for more lighter issues, issues that require less care, such as prescription refills, for example. It's really great not to have to go in for that. But if I have a concussion or something like that, is virtual care still as good an option? If I really do need a physical assessment, because what I've also heard is that patients are worried that issues might be missed without that physical assessment. I can describe to my physician how I'm feeling, but is he getting the correct picture of me from that?
No, definitely. And again, these are wonderful questions. This is reflected right into our interviews. So through our thematic analysis, a common concern for virtual care was it has to be for the right patient and for the right concern. So we know, as you mentioned, for concerns that perhaps don't require a thorough physical exam or a more serious concern, and that these consults can be done virtually. So, for example, a prescription refill, or perhaps just a verbal checkup or anything such like that. We know that patients are greatly appreciative of the time efficiency when it comes to virtual care. However, when patients are unsatisfied is when virtual care is employed inappropriately. So again, for example, an oncology consult or something that requires a physical assessment. And that's where the dissatisfaction of virtual care comes into play. So that's absolutely correct. Most of our, well, actually all of our participants on the were accessing virtual care through primary care, and therefore that is a bias within our participant sample. So it's not something more serious or a very chronic condition that has to be managed in person. However, yeah, so we know that the participants that are able to use virtual care and they don't need a physical exam or a more thorough in-person assessment, they very much enjoy virtual care. And then the issues arise when it's for the wrong patient and for the wrong condition as well. So I think the biggest thing that we would have to work with virtual care is identifying when is it appropriate to use virtual care and when is it appropriate to use in-person care, so that we can maximize the advantages of both in-person care and virtual care post-pandemic.
Great, thank you.
Of course.
All right. Well, thank you so much, Mars. And I'm going to I'm admitting it right here. I'm a horrible timekeeper, but I love research, and I wish we would have saved more time. So thank you. And I encourage all of you, this will be recorded. I invite you all to reach out to the researchers, connect with them, ask your questions. And as we try to connect and celebrate, this is along that line. So thank you so much, Mars, for taking time out of your day today to share your research with us.
Thank you so much for the opportunity. And I will post the link to our survey in the chat. Thank you.
Wonderful. Thanks so much. All right. Our next presentation is Social Contours and COVID-19, Behavioral, Perceptual, Social, and Place Dimensions of COVID-19. I'm going to turn my screen off and hand it over to Dr. Nazim Maharjareen.
Great. I thought I was going last, but this is good. This is good. Yeah, no, that's just perfectly fine. I'm just we'll bring up.
I'm sorry about that. I was questioning that because I had two different schedules here, and this is what I saw. So hopefully you're good to go, and whoever is last, hopefully they are
good to go.
A sip of water and just enjoying the morning here with us.
Here we go. Good. Hopefully people could see my screen. Good morning, everybody. It's wonderful to be here and be with you. And thanks, Elan, and everybody else who organized this event, even amidst the pandemic, to do it this way and inviting our team to present. So this is very much research in progress. I only have 10 minutes, so including maybe a question or so. I will proceed very quickly. I want to just actually set the scene very quickly in terms of what motivated us to do this particular study. And when pandemic, well, the first case was identified just mid-March, we realized that this is being a respiratory condition, that this is really predicated on behavior. And with behavior, it is also predicated of social circumstances and situations that people live in, and also perception that people have that also are very tightly connected to what they do or don't do. So the whole behavioral, social, and perceptual dimensions of SARS-CoV-2 and COVID-19 were critical, and we felt that we have an opportunity to try to dig into this area very quickly. So in early April, I got a call from a colleague here in town who was connected to a couple of teams in Switzerland and Amsterdam, and inspired by the work that was happening outside of Canada. I want to mention this. It really is connected to some work that was already going on in Geneva and in Netherlands. We created this Social Contours COVID-19 study. It's a survey, and we launched it in early May, actually May 4th, I believe, the first day of reopened Saskatchewan. What I want to do is actually do something I typically don't do, and that is to go to the final or penultimate slide and tell you what the takeaways are. And there are many takeaways. from this ongoing work. But there are 8 that I have identified here. They are actually, you could look at them as behavioral and perception related. In terms of behavior, we have behavior that will expose greater risk to the virus, as well as behavior that mitigates against getting the virus, and of course perception. So first takeaway, we looked at 10 risk exposures, and the ones that were really critical, like quite robust in terms of its significance to heightening risk exposure to the virus, were places visited, indoor places visited. I'll say a little bit more about this in a minute. Household density, exposure at work, contact intensity. The contact intensity is really how many people did you see in the last 7 days and for how long. So it's a number of people multiplied by how long. Grocery shopping were the top 5 risk behaviors that we consistently found kind of related to heightening risk exposure. We saw a doubling of high risk exposure due to indoor places visited. These are gym, fitness centers, restaurant, bars, or friends or somebody else's home, visiting somebody who you don't live with in the last 7 days. 70% increase in high risk exposure at work. Again, this is work in an indoor setting as opposed to outdoor setting, with exposure to a lot of different people, interacting with customers, clients, and so on. And this is all from May through to September, early May through to end of September. 50% reduction in high mitigation. So now I'm shifting to exposure of risk estimate to mitigation of risk. We studied a bundle of 6 behaviors, the usual suspects like using PPE, hand washing, social distancing, and staying home if you have symptoms, etc. So there was a halving of the reduction of high mitigation from May to September. 13% reduction in physical distancing when outside, but in contrast to that, 45% increase in masking consistently when you cannot physically distance. And we also found that mask wearing was not associated with compensatory behavior, meaning that wearing a mask didn't mean that they were letting go of other safe measures that they were taking, for example. And 11% drop, this is now regarding perception. 11% drop in very concerned about spreading the virus from May to September, but 38% drop in those who said people were not taking precautions. So this is kind of consistent with what we are seeing where the pandemic is at the moment. 24% drop in those who say the government is handling the pandemic well, and only 56.5% saying they will get a vaccine at the end of September compared to almost 85% at the beginning of May. So those were, I kind of lifted up a few salient findings, from the social contour study. And now I will actually just kind of try to backfill these takeaways. Our objectives are on this slide. They're really quite simple. We want to look at behavior, perceptual, social, and place-based data. We want to assign a risk level to people and places over time. So this is a longitudinal panel study, if you will, from May to September. We want to identify low and high risk places. So this is towns, Regina, Saskatoon, and now zones, the 13 zones or the 32 subzones. And we want to communicate this information to public health officials as well as to the general public. This is really just over the weekend, we were looking at the risk, behavioral risk score which is in the color-coded base layer that you see from that light brown to dark brown. And on top of that, for each of the 13 reporting zones for COVID, we put a circle that indicates the number of active cases in the last 3 completed months, August, September, October. And a couple of things you see here very quickly. One, there are many zones in Saskatchewan currently where there's a high risk behavior for contracting the virus. And then on top of that, we see that in the last completed month, meaning October, compared to August, there are a high number of cases. There isn't a tight one-to-one correlation between this behavioral risk score and the active cases yet that we're seeing here. We are showing in this kind of this teeter-totter the kind of the tension in a way that we were trying to estimate here. On the one hand, 10 behaviors that increases risk exposure to the virus, and 6 behaviors that minimizes it or reduces it, or could prevent it. So we were trying to actually understand where does any individual respondent land in this balance between risk exposure and risk mitigation. How have risk behaviors changed over time? I have 2 slides on this. Places visited in the last 7 days had actually increased the risk associated with places visited in the last 7 days from 35% in early May to 75% in end of September. And also we see that 20% work risk behavior in terms of working outside of home, 20% in early June, middle of June, to 33% at the end of September. In terms of how have mitigation behaviors changed over time, overall mitigation, which is to say the 6 mitigation behaviors that you saw in that teeter-totter on the right-hand side have been reduced, 83% in early May to about 43% in end of September. And social distancing, is decreasing, but masking has increased from 41% to about 60%. And this is a bit of a good news story in terms of masking. We are showing how the mask wearing consistently has sort of spread from June, July measurement right here to August, September. And this is the overall mask wearing in Saskatchewan, presented in the 13 zones. Maple Creek area, the southwest corner zone has less than 25% of people who are masking consistently compared to other areas. Perception of risk changing over time. We see that those who say they are very concerned about spreading the virus, decreasing the percentage of people who say that from 78% to 69% over time. Those people who say that that people around them are taking precautions for not getting the virus decreased from about 91% when we were just coming out of the lockdown to only 56% in late September. And this is interesting. We asked a couple of questions about how people view the government's handling of the pandemic. 82% in middle of May saying that they were handling the pandemic well, to only about 62% in September. But there was quite a precipitous drop in August, in early August. This corresponds quite consistently, not only here, but in other findings as well, when we had those outbreaks in congregated living communities and situations in the southern areas of Saskatchewan. And this is a concern where when asked whether people will get a vaccine if one is available, We are hearing quite a bit about vaccine these days. 85% in May, only about 56% saying they'll get a vaccine. This is probably, we know a lot about how vaccines are produced, the whole process of vaccine production, even before production, testing and so on. It is in the media. There's an infodemic going on in terms of misinformation, disinformation about vaccines, etc. So I think this is reflected in the way that people are responding to vaccines as well when asked. And I think I'm going to skip the reopening phase findings and just go back to this takeaway. So in overall, when we have tracked what people are saying that they are doing or not doing in terms of increasing risk or keeping them safe from contracting the virus, since May, since May in the fall, people have relaxed. People are not taking as many precautions, and people's perceptions of the virus is kind of is letting up, and their feelings about how the government is handling the pandemic is also decreasing, and their sense of whether they will get a vaccine if one is available has also been, I would say, compromised. And I want to just acknowledge the rest of the team here. I get to come and present this, but there are a group of people who are involved in this, and I'll just stop there, Elan, and take some questions. And I'll be happy to. I mean, this is the first time actually I'm presenting to a larger audience, Elan, and it is nice to do that. And I look forward to any comments and any feedback that people might have or ideas, either now or later after this event.
Thank you, Nazim. Always a pleasure to hear about the important research that you're doing, and this is up there. So the work that you're doing here really resonates on two levels for me personally. I'm just waiting for stuff to come in on the chat room, but number one, the importance of theories of change in terms of as we plan this, and then secondly, the role and the impact of social media research, not even social media, but I guess it is social media. It's become social media, but just looking at like the role of marketing and media in terms of behavioral change as we move forward as a community. So I've got questions coming in here. So mine was just like filling some space. Lots of great questions coming in here. I'm gonna, if we can we bring Dale Hall up to ask his question in person? And again, Nazim, we've got lots of great questions here. You'll see these after. I hope you have time this week to somehow reply to some of these people if you need any contact information, because lots of good questions, very limited time.
I always do that. Whenever I respond to every single email pretty much I get. So I'll be happy to do that.
Thank you. Dale, do we have you yet?
I'm here. Oops. I'm here. Sorry.
Great.
Yeah.
Anyways, I'm just wondering, well, I find this quite interesting, why people at the first want a vaccine, and then now that we've got halfway through it, people are now not wanting a vaccine.
Yeah.
Yeah,
actually,
there's a drop
Dale,
in that amount.
Dale, I mean, that is a surprise to us as well. When you really stop and think about what has happened, since March or so in this part of the world to now, this kind of doesn't surprise me when you really think and stop and think about it. What's been happening is we've been hearing so much about the whole process, the expedited process of vaccine development, testing, and the production, etc. There is at one time more than 100 vaccines being developed and tested, and now we are landing with about half a dozen or so. A couple of them now are ready to be produced, I guess, in mass production. We are hearing in places like Russia that, scientists, are casting doubt about how quickly, kind of, whether in the interest of time, people are cutting corners in terms of testing and so on. There's and then on top of this, Dale, what is going on is that there is a bit of a correlation between anti-vaccination and basically promulgating misinformation and disinformation about the pandemic itself. It's a hoax. It's not a big deal. We could just actually kind of live through this. This is about 5G networks. I mean, there's a whole plethora of infodemics going on. And so it makes sense in a way that this casts a shadow on how people are thinking and feeling about vaccines as well. So we've had 8 months, to kind of, receive this information alongside of credible information about vaccinations, credible information about, this pandemic. But alongside that, there is other information as well. So there are people who are vulnerable to that. People who are vulnerable to that, and that is probably reflected in that reduction of, but it might go up, when you see that vaccinations are actually being helpful. So it is not a static thing. It is constantly changing.
Okay, thank you very much.
Thanks for the question, Dale. I'm going to take one more. That we've had about 3 or 4 questions that really were pertaining to the survey. So some are coming at it from the research side, the response rate. I'm going to ask Sandy Kasser if we can unmute her, because we've got a couple questions actually asking about survey fatigue and questions, but I'll turn it over to Sandy.
Good morning. My name is Sandy. Thank you, Elan. I just had a quick question about the response rate. This is something we're witnessing. There's low response rate for electronic surveys during COVID time. So I was just wondering whether you had any challenges or any issues with the response rate in distributing your survey. Thank you.
Yeah, so very quickly, and I didn't have time to go into the design of the survey, somewhat dry for, that kind of content. But actually we went, so the Canadian Hub for Applied and Social Research, formerly known as Social Science Research Lab at University of Saskatchewan, are the survey administrators. So we actually tapped into the community panel, the Saskatchewan community panel, in order to do the survey, through Chaser or the Canadian Hub. Also, we reached out to volunteers of this survey as well. We had 5,400 responses over the 5 months from May to end of September. So we actually don't have a denominator in order to calculate a response rate as such, but but we do, what we do is that we weight the sample that we have using the 2016 census data for Saskatchewan adult population for age, sex, and location of residence in order to reflect and balance that skew that we get when we have voluntary respondents as well. So it's a hybrid survey, a community panel that reflects randomly selected, adult population of Saskatchewan, supplemented by a voluntary sample, and then weighted in order to reflect the Saskatchewan adult population. Thank you for that question. Yeah.
Great. So Nazim, on behalf of everybody online today, thank you so much for that great presentation. Very interesting research, and I encourage everybody to follow up. If you have any questions about this research, contact him directly so that we can keep the dialogue going. But definitely some very important work, and I'm going to be very interested to see how it unfolds over the next few months. So thank you for taking the time. Oh, you were muted, Nazim. So hopefully you heard that. So hopefully Belma Kamenchik is online here. She may have been waiting to go earlier. She's going to be looking at evaluating the use of media on perceptions and behavior during the pandemic. And this seems to be a reoccurring theme because there are obviously clinical implications and acute care and primary healthcare implications, but certainly the unanticipated impact of COVID has been a huge research, a huge interest to the research community. So Belma, if you're with us, I'm going to turn this screen over to you, and I welcome you on behalf of Research Showcase 2020.
Good morning, thank you. I'm just going to try and share my screen here. Okay, I'm going to assume everyone can hear me.
We can hear, I can hear you. I think everybody else can.
Yeah, you're good.
Excellent. Okay, so I think that this is very timely after that presentation. So thank you so much to all the presenters who went before me. It's some excellent work. And so my name is Belma Kamenchik. I am a third-year medical student. And along with my team, which consisted of Jeremiah Charabasam, Dr. Kalyani Premkumar, Chris Ripplinger, and Dr. Marcel Dion, what we did was evaluate the use of media on perceptions and behavior during the COVID-19 pandemic here in Saskatchewan. And so this research was done when we first started to hear that anxiety, depression, and stress were quite common reactions to the pandemic. And in Saskatchewan in particular, unlike SARS or H1N1, this is the first time we're really seeing Saskatchewan affected by a pandemic of this size. And I mean, arguably the world is as well. But this is also in context of a time where the general public has so much more access to social media and other forms of media. And therefore, with both of these factors, understanding the relationships between anxiety, between media use, and therefore protective behavior during this pandemic has very important implications for the overall mental health and safety of our population. And so this study was done as an online questionnaire that was distributed to University of Saskatchewan students and members of the general public in Saskatchewan, recruited via social media and email platforms. And so this survey was done just before a lot of the data Nazim was talking about. So it was released from April 7th to May 13th. And during this time, just for a bit of context, the approximate cases in our province had about doubled. The distribution went from more urban centers to rural. A few weeks prior to this, Italy had reached its peak of cases, and the US at around this time was sitting at 35,000 cases a day. And so there were a total of 696 participants who participated in this study. And what we found was that, number one, so 73% of participants were using more media than before the COVID-19 pandemic. The primary media platform that people used to get their COVID-related information was, number one, online news networks at 33%. Number two, television news networks at 19%. And number three, social media at 15%. And so this is interesting, as this is probably one of the first times that we're seeing social media as a primary platform for information, and especially when it's information that's so pertinent and relevant to the overall health of our population. And so of these platforms, Facebook and Twitter were the most common social media platforms that were used. And in saying so, over 70% of respondents reported feeling moderate anxiety or higher. And so these high levels of anxieties were significantly associated with that use of social media as a primary media platform. So using more social media, although we can only comment on correlation, that was correlated with those high levels of anxiety. And other variables that also corresponded to those high levels of anxiety were a higher perceived thoroughness of the media coverage, a greater perceived self-COVID-19 risk, and being female. So interestingly, variables that were not correlated included age. So depending on the age spectrum, anxiety was kind of present throughout. And with that, we also did a Pearson product moment correlation test and found that engagement in a higher number of protective actions was significantly associated with higher levels of anxiety and a higher number of media platforms used, although the relationships were very weak. So it's difficult to say necessarily what drives that kind of protective behavior, although potentially intuitively that higher level of anxiety can cause people to engage in more protective actions, as well as using more media platforms, so engaging more in what's out there for information. And so with that said, though, over 70% of participants experience this moderate anxiety or higher. And while this seems good in terms of engaging in protective behavior, this should also alert us to the possible distress and increasing mental health problems that our society may be facing, and some of the presenters have already touched on, and therefore the need to identify at-risk individuals. And so while anxiety does have the potential to encourage protective behavior, a balance must ultimately be struck. And so in particular, optimizing social media use may be an important way to reduce that excessive anxiety. Sorry about that. And then furthermore, this can also be a point of seeing that if social media is a place where people are experiencing more anxiety or engaging more with this platform, that's also a good place to target potentially some mental health resources is on some of those platforms. And so in conclusion, the use of social media as a primary platform for COVID-19 was associated with greater anxiety. And there is evidence to support that increased anxiety and increased media platform use are associated with engagement in a higher number of protective actions. So for future directions in this study, we are planning to repeat this in a few months' time to assess how do our outcomes change versus April and May, and now here in November. The study has also been completed in India, and the results are just being tabulated right now. And that'll be a way for us to compare how culturally and like systematically the different ways of dealing with the pandemic impacts the population. And so I'd just like to thank my research members and Brianna Groot, Dr. Cody Phillips, and Udoko for their contributions for this project. And I'll open it up to questions.
Thelma, thank you so much. That was amazing. I'm not sure if you knew, and I didn't want to interrupt you because you had such a wonderful flow going and I was so engaged with everything you were saying. There was no sharing screen. So
oh no.
I know.
Here.
So if there's anything, if you'd like to
I'm so sorry. This should have been on there.
There we go. Okay.
Okay.
Wonderful, Thelma. I just didn't want to interrupt you because there was never a good time. I was listening so intently there. But
sorry, I must not have clicked the share button there. That's what should have been up there.
Don't worry. So that's wonderful. And I've got the chat room going up here, but just before, I love the idea too, because, you know, Saskatchewan is such a microcosm of so many cultures here that I love the idea that you've reached out, you're doing the same sort of work in other countries, which I think may or may not have some implications for the work that you're doing here. I see the chat box lighting up here. So, oh, there we go, hang on. Sorry here. I'm not good at doing both here. Belma, was there a specific part, like I'll give you like 30 seconds just to hone in on something that, being that nobody, we saw you presenting and you did a great job.
I am so sorry.
But if there's anything you want to actually highlight while I see, I've got a question here from, I'm not sure, could it be Dr. King or it's M. King? If we could unmute him or her for their question.
Hi, this is Maggie King.
Ah, okay, thank you. Hello, nice to have you on board here. Go ahead. Thank you for joining in.
Yeah, I was interested in her topic because on social media, I do get a lot of my information about stress relief in terms of grief, mental health, and a lot of my friends are on social media are mental health workers and elders, and they provide me with a lot of sources of mental health resources, and also they help relieve the stress of COVID impacts and just being able to keep in touch with people through social media really helps relieve a lot of that stress. And I know that I can rely on their expertise because they are social workers and they are very good at the work that they do, and helps me in terms of what's happening in my life to connect with them. So I agree with her research that social media can be an important source of relief for people who are unable to go out in the world and meet their friends and family like we used to do before. So thank you.
Thank you.
Thelma, we have a question here, and just because I think that we see this a lot. I'm not a big social media guru by any means. I'm more of a voyeur. I'm not a poster, but I do like to see what's happening. I'm going to turn it over to Sandy Kasser again here. She's got a question about mask wearing and social media.
Hello, Belmont. This is Sandy. I apologize. I think I'm kind of typos there, but I was asking whether you've noticed there any reports about shaming about wearing the mask or not, when, especially in the early stages of the pandemic versus right now where it's almost mandatory in every place. So I was just wondering if you had any information on that. And thank you so much for this great presentation.
Thank you. We didn't look at in particular mask wearing, and we aggregated the results just for protection of whoever was answering the survey, because there was some contention at that time when it came like legally and whatnot. So we didn't look necessarily, we just kind of aggregated the results as a protective value. But I think we see more and more now. I agree with you about these anti-masking campaigns and whatnot. So I'm sorry, I can't comment more to that.
Oh, that's perfect. Thank you.
Thank you.
All right. Well, thank you, Belma. And for those of you that did not see, well, we didn't see it. We'll maybe, Belma, what do you suggest? Can you put a link, or can we actually post this? We can actually get this up on our website as well, but I'd love for people to be able to see your poster here and be able to do it. I'm getting lots of chat box stuff. Great work. Good job. So you didn't need your poster. You were able to carry the presentation by yourself. But I think it would be great for everybody to be able to see some of the data that you've accumulated so far.
Absolutely, I'll send that over. Thanks for bearing with me.
No, it was great. Thank you, Belma, on behalf of the organizing committee. We appreciate the work that you're doing and for taking time to be with us this morning.
Perfect. Thank you so much.
All right, so thank you. We're going into, if I can actually do this, we're going into our final presentation here for this morning's session, which is, there we go, the epidemiology of COVID-19 in Saskatchewan. And I believe Dr. Maureen Anderson will be our lead presenter on this project. So Dr. Anderson, are you with us this morning?
I am, thank you.
Awesome. I'm going to stop my screen and make sure that we've got your screen up and going here before we proceed. Always nice to see you.
Oh, you too. All right, so I'm just going to share my screen here. So we are all COVID all the time today, and I think that's probably where everybody's mind is these days anyway. But I'm going to try and stick on time because I know I'm between you and lunch, but thank you everybody for being here today. Again, as Dr. Paluck mentioned, I happen to be the one talking, but this is a huge team effort, and we'll get to those folks in a second. Briefly about myself, I spent the substantive portion of my career with the Canadian Public Health Service, Public Health Agency of Canada. I'm really pleased to be back in my home province after having worked worked as a public health epidemiologist across the country in nearly every provincial jurisdiction, mainly doing outbreak response and control. And it's funny that I feel like I used to always have to explain what an epidemiologist was, and now I feel like we're all epidemiologists. Everybody is a practicing epidemiologist. So as a disclaimer, please know that the views that I'll express are not necessarily those of the government and the folks that I've been working with in public health. And I really want to just acknowledge that today this work is really dedicated to the public health workforce in Saskatchewan. I was just on a COVID call with them just before this, and folks are working literally 18 to 20 hours a day to try and prevent and mitigate viral spread in our home province. So just to set a bit of a context, I think probably everybody knows most of this, and SACP did a great job of going through the epidemiology of the beginning of the outbreak as well. But we had the ProMed post that came out on December 30th, 2019, just asking for some more information of undiagnosed pneumonia in China and Hubei province. I think twigged to all of us in public health that you know, this is an important post to think about. I just want to add that a fun fact. So Taiwan took some of the first great public health action outside of China, and I know that correlation does not imply causation, but I think it's an interesting fact that the Taiwanese vice president is an epidemiologist by training. We found at the beginning that the information largely on the outbreak was available in Mandarin. And so I just want to really acknowledge Dr. Nate Osgood and his team here in Saskatchewan. And I think Jenny Basram was on the call earlier. We are so fortunate to have the Osgood lab in this province. They are just as good, if not better, than most of the modeling groups internationally, and they work with the Australian CDC and others. Their team had been doing data mining of WeChat, which is like a WhatsApp group that's in China, in Mandarin, and have been working on this since December and January. GFIN, so that's the Global Public Health Information Network with the Public Health Agency of Canada. I will encourage you, just to lack of time, I won't go into details though, but I'll encourage you to look at, a friend of mine wrote an article in the Globe and Mail on our lack of funding for GFIN in Canada, which was an issue at that time. And then there was a really great joint mission to Wuhan that WHO led, and it was actually led by a Canadian epidemiologist. And they produced a seminal report on what was happening on the ground. In Canada, we have Dr. Teresa Tam, who's a fantastic leader. She supervised me on an avian influenza outbreak a long time ago. Now I'm dating myself. But she, at that time, said active surveillance was focused on returning travelers, which it was. Our first case in Canada came in Toronto on January 25th, and we were learning in real time. So in Canada, we had Canadians repatriated to the Trenton military base in Ontario. I have some friends and colleagues, and I remember the pictures of them, you know, smiling and working with the Canadians that were repatriated to the country at that time. And we were learning in real time, and that's, as Sakop has mentioned too, this is all about data for action and sort of juggling that precipice that we stand on between providing the best evidence for information and action in real time, while also, you know, trying to do the research that's needed. And it's important to think about some of those things that we just didn't know. And this is what's really exciting about science, is that we don't know, and we get to learn in real time. But I'm sure as a general population, that is not super exciting and fun to have that happening in real time. But one of those examples is the role of asymptomatic carriers. So we know that there's a much larger role of asymptomatic carriers than we maybe initially thought in January. And Quebec had the first declaration of a public health emergency in Canada. So this public health emergency, we know that in the absence of public health measures, SARS-CoV-2 will produce a hot burn. And if it's allowed to gather momentum, it will overwhelm healthcare systems. And we've seen this time and time again all around the world. Affected populations will vary depending on the setting and mixing patterns. And until we can achieve herd immunity, we need to dampen transmission to a slow burn so we don't exceed that healthcare system capacity. And that slow burn is going to be achieved through public health measures, and Saskatchewan is not an exception to this. And as I mentioned, we don't have a textbook or a manual to guide us, and we need to learn as we go. Again, exciting for scientists and not so for the rest, I'm sure. I just want to acknowledge Leslie Bell, who has created this great slide for us here today. showing the 4 Western Canadian provinces with COVID. It's important to look at our testing rates as well as the case rates, because the testing rates are indicative of active case finding, and so will be, it's important to interpret those 2 things together. So you can see the Saskatchewan active case rate is in green, BC in blue, and Alberta in orange, and our colleagues in Manitoba are also working 20-hour days and are up here, and you can see the testing rates in the background there. Saskatchewan, I want to acknowledge Tracy Creighton and her amazing GIS work, who's been so instrumental in helping to visualize and guide public health action in our home province. So here again is the active case rate and the test rates by the ministry subzones. And then I'll just quickly show our epidemic curve. So this is one of the tools that are used by epidemiologists, are one of our basic tools of person, place, and time. So to show at the beginning, so we had some returning travelers. We had an outbreak here in May in the north. We had some increase largely in Hutterite colonies in the summer. And then here's where we are today. And as Seka mentioned, we're really at the most critical and most difficult point of the epidemic so far. So I'm just going to give an example again of sort of this data for action and how we try and provide the best information possible in real time for folks making tough decisions. So this is just an example of some of the indicators that we've been monitoring. And again, some of the things that aren't here are, there's lots of other indicators that we do monitor over time, but just to give you a bit of a flavor. And it's important to think about these indicators are all lagging. So at the point that someone is exposed, there's an average incubation period of the organism, which is about 5 days. They then maybe get tested, they maybe get lab confirmed, and then to self-isolation. So there's a lag time in indicators, and we find it's approximately 2 weeks. And with more severe indicators like deaths, we're looking at, those are reflective of actions occurring about a month ago. So our current situation in Saskatchewan, we're not in a steady state. Our active cases are increasing week to week. We've had the highest number of cases and hospitalizations and deaths since the beginning of the pandemic. We now have viral seeding throughout the province. Our active outbreak investigations have increased, associated with workplaces, bars, schools, gyms, churches, healthcare facilities, shelters, rinks, bowling alleys. I think it's important to note that school-associated cases have largely not resulted in school or community-based transmission, and they really just reflect those underlying community-based transmission rates. There's local variation in transmission patterns, and they're going to change rapidly and unpredictably as we continue. As our surge continues, the ability for any jurisdiction globally to effectively test, trace, and isolate determines how well they can emerge from a surge. And this is that daily work of public health. And again, just recognizing those folks that are working day and night to do that. This is just an example that we give for folks to try and really understand the magnitude of the numbers of contact tracing. So for every case, this is Saskatchewan specific data, we have an average of 5 to 8 contacts. So if, for example, we report 159 new cases in a day, public health will need to notify conservatively, if we multiply that by 5, over 1,000 new contacts, and plus those 159 new cases. They have to get in contact with all of those people in one day. And then that repeats day after day after day. So it's thousands. To date, a total of almost 24,000 contacts have been investigated in Saskatchewan. On almost a quarter of those were just in the last 2 weeks. And we do know that among close contacts, about 1 in 10 will become a case. And several studies have estimated that 10 to 20% of cases cause about 80% of new infections, which helps guide priority contact tracing. And I'll just give a little quick shout out to our Public Health Agency of Canada colleagues who've developed the COVID Alert app, which is a great pan-Canadian, well, not every jurisdiction, but a lot of Canadian jurisdictions have adopted this app, which also facilitates interjurisdictional notification. So please download this COVID Alert app. The population level interventions, I think this comes as no surprise to this entire group, so I won't belabor it. But again, we know the non-pharmaceutical interventions that work: universal mask wearing and physical distancing. frequent hand washing. And we talk about, this is not a surprise to our quality improvement folks who've talked about the Swiss cheese model for years, but it's that sort of thing where, you know, if you think about different layers of the cheese, of distancing and masks and cleaning and hand washing, and, you know, there's virus can get through those little holes, but the more you layer on, the less viral transmission occurs. So the research program that we are proposing and embarking on, and I just really want to acknowledge and thank the so many people who have been making this possible since the beginning, but particularly SHA Research Services and Academics and Learning. I really want to thank the efforts that they've made to have this come as a possibility. So this is a collaborative effort of public health practitioners, research services, laboratorians, epidemiologists, analysts, and physician leadership. We are using routinely collective administrative health data for this work. So from the case investigation information in Panorama, our provincial lab, our contact tracing data. And in the future, I'd like to acknowledge the collaboration that Saskatchewan Health Quality Council has graciously offered to help link our data to administrative healthcare data, which will help inform other research questions. So what are those questions? This is just an example. We're looking at you know, what is the symptomology of cases in relation to duration and or illness outcome, all the way down to what is the primary exposure setting in each of the outbreak clusters and how many cases arose. We're proposing lots of descriptive analyses and regression analyses, and it's important to consider equity. We know that the pandemic has disproportionately affected our most vulnerable, and this needs to be considered in each of the analyses we conduct. So I'll just, in closing, say that I know all of you know this, but the actions taken by the people of Saskatchewan will determine our health outcomes, and that simple measures really do reduce that risk of infection. So outdoors is better than indoors, masks are better than no masks, please physically distance. All of these types of behaviors will spread germs, wash hands, stay home, and reduce contacts and non-essential travel. And again, I happen to be talking, but this is the labor of so many folks. So thank you to all of them. And thanks for your attention and time.
Thank you so much, Dr. Anderson. That was extremely important work. And I think, you know, listening to this, it just really highlights what Scott said in the opening comments about how quickly researchers have pivoted to what's really important here, which is something that has long been a criticism of research, that we are just, you know, always a little bit behind, or the implementation. And so certainly this is the perfect example of research that's really real time and so on. We've got a very good question here from, I'm not sure, Dinesh. I'm sorry, I'm probably just really butchering this, but everybody's names are a little bit different here. Dinesh Hara.
Yeah.
Thank you. Please introduce yourself. And I'm so sorry for doing that to your name. I know it's just.
I'm Dinesh Tharel. I'm a graduate student in community health and epidemiology. Thank you for a very timely information about the COVID situation. I was wondering if we know about the characteristics of the high-risk contacts, given the fact that there are certain contacts who are leading to the chunk of positive cases.
Thanks for the question. We do. So we know that the more repeated exposure over time, then there's more likely to become a case, which makes sense. In terms of high-risk contacts, I have some good information on some social networking analyses that Dr. Alazim and some others have done, and I'm happy to follow up with you after if you're interested.
Thank you.
Thank you, Dinesh. So we are a little bit over here, and so Dr. Anderson, thank you so much for this important work. Lots of really positive comments in the chat room. Hopefully you'll be able to access those through media. And again, I encourage anybody that didn't get a chance to have their question answered to reach out directly to Dr. Anderson and connect in that way, because this is really what the intent of this event is. So thank you again for sharing the important work that you're doing. And as usual, it's a pleasure to have you as part of the team here.
Thanks for the opportunity and the support. Thanks.
Great. All right. Thanks, everyone. Oh, look, okay, we saw some hand claps there. I forgot to give mine. That's my only thing I really know how to do on, on Zoom here. Thank you, everyone. We're going to reconvene at 1 o'clock. We have a new session beginning, and I'm trying to look at my calendar here. At 1 o'clock, we have the patient partner coffee chat. And immediately following that at 2 p.m., we have our same idea, the Saskatchewan Snapshots, which is the clinical and health services research forum. So enjoy your lunch. Thank you, everyone, for being so engaged and an important part of this morning. Goodbye.